Welcome to this NCLEX maternity review for nursing students. In this lesson, we'll cover the most important maternity concepts that frequently appear on the NCLEX. Instead of memorizing isolated facts, we'll focus on understanding why nursing interventions are performed and how to prioritize care using NCLEX-style thinking. Today, we'll review prenatal care, the stages of labor, fetal heart rate monitoring, common obstetric emergencies, postpartum care, and newborn assessment. Along the way, I'll highlight key memory tips and clinical priorities that can help you answer exam questions with confidence. By the end of this lesson, you'll have a solid foundation in high yield maternity nursing concepts and be better prepared for both your exams and clinical practice. So let's get started. During pregnancy, a woman's body undergoes major physiological changes to support the developing fetus. One of the most significant changes is an increase in cardiac output by approximately 30 to 50%, along with a 40 to 50% increase in blood volume. These adaptations ensure that the fetus receives enough oxygen and nutrients throughout the pregnancy. The respiratory system also adapts by increasing oxygen demand, so many pregnant patients may experience mild shortness of breath with activity. As the uterus enlarges, it places pressure on the bladder, leading to urinary frequency, especially during the first and third trimesters. Hormonal changes can slow gastrointestinal motility, contributing to constipation, while nausea and vomiting, commonly called morning sickness, are most common during the first trimester. Routine prenatal care is essential for monitoring the health of both the mother and fetus. A common NCLEX question asks about the prenatal visit schedule. Visits occur every 4 weeks until 28 weeks gestation, every 2 weeks until 36 weeks, and then weekly until delivery. During these visits, healthcare providers monitor maternal health, fetal growth, and screen for pregnancy related complications. Patient education is another important nursing responsibility. Encourage a balanced diet, adequate hydration, daily prenatal vitamins containing folic acid, and avoidance of alcohol, smoking, and drugs. Finally, nurses must teach patients to recognize danger signs that require immediate medical attention. These include vaginal bleeding, severe headache or vision changes, leakage of fluid, decreased fetal movement, and severe abdominal pain. While many pregnancy discomforts are expected, these symptoms may indicate serious complications and should never be ignored. For the NCLEX, remember this key principle. Expected physiological changes are common, but severe or sudden symptoms always require further assessment and prompt intervention. Now let's look at fetal development and the assessments nurses use to monitor fetal well being throughout pregnancy. These assessments are commonly tested on the NCLEX because they help determine whether the fetus is developing normally. First, remember that the normal fetal heart rate ranges from 110 to 160 beats per minute. A heart rate within this range is reassuring and indicates adequate fetal oxygenation. A rate below 110 or above 160 requires further assessment because it may indicate fetal distress or another complication. Another important assessment is fundal height. Between 20 and 36 weeks of pregnancy, the fundal height in centimeters should approximately equal the gestational age in weeks. For example, a woman who is 28 weeks pregnant should have a fundal height about 28 centimeters. Significant differences may suggest fetal growth restriction, multiple pregnancy, or incorrect dating and should be investigated further. Fetal movement, also known as quickening, is usually first felt between 16 and 20 weeks. A decrease in fetal movement later in pregnancy is an important warning sign and should always be reported, as it may indicate reduced fetal oxygenation. Severe prenatal tests are also used to evaluate fetal health. An ultrasound assesses fetal growth, anatomy, placental location, and amniotic fluid. The non-stress test, or NST, monitors the fetal heart rate in response to fetal movement. A reactive NST is reassuring because it indicates the fetus is receiving enough oxygen. The biophysical profile, or BPP, combines an ultrasound with an NST to evaluate fetal breathing, movement, muscle tone, amniotic fluid, and heart rate. Finally, amniocentesis collects a sample of amniotic fluid to detect genetic disorders or assess fetal lung maturity when indicated. For the NCLEX, remember this key point. A reactive NST is reassuring, while decreased fetal movement or an abnormal fetal heart rate should always prompt further assessment. Stages of labor. Labor is divided into 4 stages, and understanding each stage helps nurses anticipate the needs of both the mother and the baby. Stage 1 begins with the onset of true labor contractions and ends when the cervix is fully dilated at 10 centimeters. It has 3 phases. The latent phase, from 0 to 6 centimeters, is when contractions are usually mild and become more regular. The active phase, from 6 to 8 centimeters, involves stronger, more frequent contractions and faster cervical dilation. Finally, the transition phase, from 8 to 10 centimeters, is the most intense stage, with very strong contractions occurring every 2 to 3 minutes. During stage 1, the nurse monitors contraction patterns, fetal heart rate, maternal vital signs, and provides comfort measures such as breathing techniques, position changes, and emotional support. Stage 2 begins once the cervix is fully dilated and ends with the birth of the baby. During this stage, the mother actively pushes with contractions. Nursing priorities include coaching, effective pushing, monitoring fetal heart rate, preparing for delivery, and ensuring a safe birth. Stage 3 starts immediately after the baby is delivered and ends with the delivery of the placenta, usually 5 to 30 minutes. The nurse assesses the placenta to ensure it is intact. The nurse should monitor maternal bleeding and administers oxytocin as prescribed to promote uterine contraction and reduce the risk of hemorrhage. Stage 4 is the immediate recovery period, lasting approximately 1 to 4 hours after birth. This is when the mother is at greatest risk for postpartum hemorrhage. The nurse frequently assesses the uterine fundus to ensure it is firm and midline, evaluates the amount of lochia, monitors vital signs, and checks bladder status because a full bladder can prevent the uterus from contracting effectively. For the NCLEX, remember that after delivery, maternal stabilization comes first. If a postpartum patient has heavy bleeding, your priority is to assess the fundus. A boggy uterus is a common cause of postpartum hemorrhage and requires immediate intervention, including fundal massage and notifying the healthcare provider if bleeding persists. Fetal heart rate monitoring is one of the highest yield maternity topics on the NCLEX because it provides valuable information about fetal oxygenation during labor. The first value to remember is the normal baseline fetal heart rate, which ranges from 110 to 160 beats per minute. A baseline within this range is considered reassuring when accompanied by normal variability. Next are accelerations, which are temporary increases in the fetal heart rate. Accelerations usually occur with fetal movement and indicate that the fetus is well oxygenated. On the NCLEX, accelerations are almost always considered a positive and reassuring finding, so no intervention is needed beyond continued monitoring. Early decelerations are gradual decreases in the fetal heart rate that mirror uterine contractions. They are caused by fetal head compression during labor and are considered an unexpected, benign finding. Again, no intervention is usually required other than continued observation. Variable decelerations are abrupt irregular drops in the fetal heart rate caused by umbilical cord compression. The first nursing intervention is to reposition the mother, usually to her left side, to relieve pressure on the cord. Additional interventions may be needed if the pattern persists. The most concerning pattern is late decelerations. This occur after the peak of the uterine contraction and indicate uteroplacental insufficiency, meaning the fetus may not be receiving enough oxygen. This requires immediate nursing action. A helpful memory aid is Lion. Place the mother in the left lateral position. Increase IV fluids. Administer oxygen. And notify the healthcare provider. If oxytocin is being infused, it should be discontinued because it can increase uterine contractions and worsen fetal oxygenation. For the NCLEX, remember this simple rule. Accelerations are reassuring. Early decelerations are expected. Variable decelerations suggest cord compression, and late decelerations are the most urgent because they indicate fetal hypoxia and require immediate intervention. There are 4 obstetric emergencies that require rapid recognition and intervention. First is preeclampsia, which involves new onset hypertension after 20 weeks of pregnancy and may include evidence of organ involvement. Warning signs include a severe, persistent headache, visual changes, right upper quadrant or epigastric pain, and hyperreflexia. If a seizure occurs, the condition is classified as eclampsia. Nursing priorities include notifying the healthcare provider, initiating seizure precautions, reducing environmental stimulation, and administering magnesium sulfate as prescribed. During a seizure, protect the patient from injury, maintain the airway, and position them laterally when possible. Preeclampsia can affect the brain, liver, kidneys, and placenta, making early recognition is essential. Next, remember the major difference between placenta previa and placental abruption. Placental previa typically causes painless, bright red vaginal bleeding and a soft uterus. Because the placenta may cover the cervix, never perform a vaginal examination unless placental location has been confirmed and the provider has determined it is safe. Placental abruption usually presents with sudden abdominal or back pain, uterine tenderness or rigidity, and bleeding that may be visible or concealed. The nurse should monitor maternal vital signs, fetal status, and signs of shock. Umbilical cord prolapse occurs when the cord moves below the presenting fetal part and becomes compressed. A sudden, prolonged, or severe variable deceleration may be the first clue. Call for help immediately. Use a sterile gloved hand to lift the presenting part away from the cord. Position the patient in knee chest or Trendelenburg and prepare for emergency delivery. Finally, shoulder dystocia occurs when the fetal head delivers, but the shoulders become trapped. You should call for assistance. Help place the patient in the McRoberts position and apply suprapubic pressure as directed. Never use fundal pressure because it can worsen the impaction. For the NCLEX, focus on the first safe action. Recognize the emergency. Call for help. Support maternal and fetal oxygenation. And prepare for rapid delivery when necessary. Let's review the medications that are commonly tested on the NCLEX and frequently used in obstetric nursing. First is oxytocin, also known as Pitocin. It is used to induce or augment labor and to prevent or treat postpartum hemorrhage by stimulating uterine contractions. While administering oxytocin, nurses must continuously monitor the contraction pattern and fetal heart rate. If contractions become too frequent or prolonged, known as uterine tachysystole, or if the fetus shows signs of distress, the infusion should be stopped immediately and the healthcare provider notified. Next is magnesium sulfate, which is the medication of choice for preventing and treating seizures in patients with severe preeclampsia or eclampsia. It is important to remember that magnesium sulfate is not an antihypertensive. Its primary purpose is seizure prevention. Nurses should closely monitor respiratory rate, deep tendon reflexes, and urine output because magnesium is excreted by the kidneys. Toxicity may occur if the medication accumulates, leading to respiratory depression, absent reflexes, and decreased uterine output. The antidote for magnesium sulfate toxicity is calcium gluconate, and this should always be readily available. Terbutaline is a tocolytic medication used to temporarily suppress uterine contractions in preterm labor. Because it stimulates beta adrenergic receptors, common maternal side effects include tachycardia, palpitations, tremors, and nervousness. The nurse should monitor maternal heart rate and assess both maternal and fetal status during therapy. Finally, Rh immune globulin, commonly called ROGAM, is given to Rh negative mothers who have not developed antibodies against Rh positive blood. It helps prevent maternal sensitization that could affect future pregnancy. It is typically administered around 28 weeks gestation and again within 72 hours after delivery if the newborn is Rh positive. It may also be given after events such as miscarriage, amniocentesis, abdominal trauma, or bleeding during pregnancy. For the NCLEX, remember this high yield point. If you see magnesium sulfate in a question, immediately think about monitoring respirations, deep tendon reflexes, and urine output. And remember that calcium gluconate is the antidote for toxicity. Following birth, the nurse must assess the mother systemically because postpartum complications can develop quickly. A helpful memory aid is Bubble HE. B stands for breast. Assess for engorgement, nipple damage, and effectiveness of breastfeeding. U stands for uterus. The fundus should feel firm, remain near the midline, and gradually descend as the uterus returns to its pre pregnancy size. A boggy uterus indicates poor uterine contraction and increases the risk of postpartum hemorrhage. The next B is bladder. A distended bladder can push the uterus away from the midline and prevent it from contracting effectively. Encourage the patient to void and reassess the fundus afterward. The following B represents bowel function, including bowel sounds, constipation, and discomfort. L stands for lochia. Assess its amount, color, clots, and odor. Lochia normally progresses from red rubra to pinkish brown serosa and finally to yellowish white alba. It should gradually decrease rather than suddenly become heavier. E represents the episiotomy, perineum, or surgical incision. Use the REEDA framework: redness, edema, bruising, discharge, and approximation. The H refers to the lower extremities. Assess for unilateral warmth, redness, swelling, or pain, which may indicate a blood clot. The final E represents emotions, bonding, and coping. Postpartum hemorrhage is one of the most important complications to recognize. Heavy bleeding, large clots, dizziness, tachycardia, or hypotension require immediate action. When the uterus is boggy, the nurse's first action is to massage the fundus and assess for bladder distension. Oxytocin and additional treatment may then be required. Also, teach the patient to seek urgent care for severe headache, visual changes, difficulty breathing, chest pain, fever, foul smelling discharge, leg swelling, or thoughts of harming themselves or the baby. For the NCLEX, remember, a boggy uterus with heavy bleeding suggests uterine atony, so massage the fundus first. If the uterus is already firm but bleeding continues, suspect trauma such as a laceration. Immediately after birth, the nurse assesses how effectively the newborn is adapting to life outside the uterus. One of the first tools used is the APGAR score, completed at 1 and 5 minutes after birth. APGAR stands for appearance, pulse, grimace, activity, and respirations. Each category is assigned a score of 0, 1, or 2 for a maximum score of 10. A score between 7 and 10 generally suggests that the newborn is adapting well. However, the APGAR score is used to describe the newborn's condition and response to resuscitation. It should not delay immediate interventions when the baby is not breathing effectively. Normal newborn vital signs differ from adult values. The heart rate is generally between 110 and 160 beats per minute, and the respiratory rate is approximately 30 to 60 breaths per minute. Newborn respirations may be irregular, but persistent grunting, nasal flaring, retractions, or central cyanosis are abnormal and require immediate assessment. Thermoregulation is another major priority because newborns lose heat quickly. Immediately after birth, the newborn should be dried, wet linens removed, and skin to skin contact initiated when the infant is stable. A hat and warm blanket may also be used. Cold stress increases oxygen and glucose consumption, so maintaining warmth supports both respiratory and metabolic activity and stability. Routine newborn care also includes vitamin K, which supports blood clotting and prevents serious bleeding. Erythromycin eye ointment may be administered to reduce the risk of neonatal eye infection. Identification bands should be checked carefully, and newborn screening, hearing testing, and safe sleep education should be completed according to policy. Nurses must recognize warning signs such as central cyanosis, a respiratory rate above 60, grunting, poor feeding, lethargy, temperature, instability, or abnormal muscle tone. For the NCLEX, remember the immediate priorities after birth. Provide warmth, dry and stimulate the newborn, assess respirations and heart rate, and intervene quickly when signs of respiratory distress are present. As we finish this maternity review, let's bring together the most important concepts you should remember for the NCLEX. Begin with the essential values. The normal fetal heart rate is 110 to 160 beats per minute. A newborn's heart rate is also generally 110 to 160, while the respiratory rate is approximately 30 to 60 breaths per minute. Full cervical dilation is 10 centimeters, and a reactive non stress test is considered a reassuring sign of fetal well being. For fetal heart rate patterns, remember VL CHOP. Variable decelerations indicate cord compression. Early decelerations result from head compression. Accelerations are okay and reassuring. Late deceleration suggests placental insufficiency and possible fetal hypoxia. When late decelerations occur, remember lion. Place the patient in the left lateral position, increase IV fluids, provide oxygen when clinically indicated, and notify the healthcare provider. If oxytocin is infusing, stop it because excessive contractions may further reduce placental blood flow. Next, remember your emergency priorities. A boggy uterus with heavy bleeding requires fundal massage first. Painless, bright red bleeding suggests placenta previa, while painful bleeding with a firm or tender uterus suggests placental abruption. For cord prolapse, call for help and manually lift the presenting fetal part away from the cord. Signs of magnesium toxicity include respiratory depression, absent reflexes, and decreased urine output, with calcium gluconate available as the antidote. For newborn care, the immediate priorities are warmth, drying, stimulation, and assessment of respirations and heart rate. On NCLEX questions, do not simply ask which answer sounds medically correct. Ask which patient is least stable, which finding threatens oxygenation or circulation, and which nursing action prevents the greatest harm. Use this sequence. Recognize the concerning finding, prioritize the immediate threat, intervene safely, and then reassess the response. Maternity nursing is unique because every decision may affect both the mother and the baby. One careful assessment performed at the right time can protect two lives. Now let's test your knowledge with these comprehensive NCLEX-style questions. Question 1. A client at 39 weeks gestation is receiving oxytocin for labor induction. The fetal heart rate tracing shows a baseline of 170 beats per minute, minimal variability, and recurrent late decelerations. Contractions occur every 90 seconds and last 100 seconds. Which action should the nurse take first? It's B. Discontinue the oxytocin infusion. The client is experiencing uterine tachysystole with a non-reassuring fetal heart pattern. Oxytocin stimulates uterine contractions and can decrease uteroplacental blood flow when contractions are too frequent or prolonged. The nurse should stop the oxytocin immediately to remove the likely cause of fetal compromise. Repositioning, increasing IV fluid, continued fetal assessment, and notifying the provider should follow. Oxygen is not automatically the first intervention for every abnormal tracing and should be used according to maternal oxygenation and institutional protocol. Current fetal monitoring guidance emphasizes evaluating the complete tracing and correcting reversible causes. Question 2. A client at 35 weeks gestation arrives with sudden severe abdominal pain. The uterus is firm and tender. The fetal heart rate is 95 beats per minute, and only a small amount of dark vaginal blood is visible. The client's blood pressure is 88/54, and heart rate is 124 beats per minute. Which interpretation is most accurate? It's C. Concealed hemorrhage may be causing maternal shock and fetal compromise. The findings strongly suggest placental abruption. Blood may collect behind the placenta, so visible vaginal bleeding can significantly underestimate the actual blood loss. The painful, rigid, or tender uterus, maternal shock, and fetal bradycardia indicate a severe obstetric emergency. Question 3. A postpartum nurse notes that a client has heavy vaginal bleeding and a boggy uterus. What should the nurse do first? It's B. Massage the fundus. A boggy uterus indicates uterine atony, the most common cause of postpartum hemorrhage. Thus, fundal massage is the first nursing intervention. Question 4. The nurse observes late decelerations on the fetal monitor. What is the nurse priority action? It's C. Place the client in the left lateral position. Late decelerations indicate uteroplacental insufficiency. First nursing interventions include left lateral position, increase IV fluids, oxygen if indicated, stop oxytocin if infusing, and notify provider. Remember Lyons. Question 5. A newborn is delivered through meconium stained amniotic fluid. The newborn has a strong cry, good muscle tone, and a heart rate of 148 beats per minute. Which action is most appropriate? It's C. Provide routine initial newborn care while continuing assessment. A vigorous newborn with meconium stained fluid does not require routine intrapartum and endotracheal suctioning. Routine initial care includes maintaining warmth, drying, positioning the airway as needed, and ongoing evaluation. Question 6. A nurse is assessing a client at 30 weeks gestation. Which findings should the nurse report to the healthcare provider immediately? C. Severe headache with blurred vision. Severe headache and visual disturbances are warning signs of preeclampsia and require immediate evaluation. A is common discomfort of pregnancy. B is expected due to uterine pressure. And D is a common gastrointestinal change. Question 7. A nurse is caring for a postpartum client using the Bubble HE assessment. Which assessments are included? Select all that apply. It's A, B, D, E, F. Bubble HE stands for breast, uterus, bladder, bowel, lochia, episiotomy or perineum, homens or extremities, and emotions. Lungs are not part of the mnemonic. Question 8. The nurse receives report on 4 clients. Which client should be assessed first? It's D. A laboring client with recurrent late decelerations, minimal variability, and a uterus that does not relax between contractions. Recurrent late decelerations, minimal variability, and a uterus that fails to relax suggests reduced uteroplacental perfusion and possible evolving fetal hypoxia. This client requires immediate intervention, including stopping oxytocin if it is infusing, repositioning, assessing maternal status, correcting reversible causes, and notifying the obstetric team. A. These are generally expected early postpartum findings, although ongoing assessment remains necessary. B. Choice B. Placenta previa is serious, but this client is currently hemodynamically stable with a reassuring fetal status. The nurse should maintain precautions and avoid digital vaginal examination. Choice C. These findings are near monitoring thresholds but do not currently indicate clear magnesium toxicity. The nurse should continue close monitoring. Question 9. A postpartum client is receiving oxytocin for uterine atony. Despite fundal massage and empty bladder, the uterus remains boggy and bleeding continues. Which findings should the nurse identify as evidence of worsening hypovolemia or impaired perfusion? Select all that apply. Correct answers are A, B, C, and E. Early or worsening hypovolemia may present with the correct choices. For choice A, tachycardia as compensation for reduced circulating volume. Choice B, reduced urine output from decreased renal perfusion. Choice C indicates anxiety or restlessness from reduced cerebral perfusion. And choice E, pale, cold, and clammy skin is usually caused by peripheral vasoconstriction. Postpartum hemorrhage can progress quickly and require standardized, rapid management. Choice D is incorrect because a small blood pressure decrease may not independently demonstrate shock. Blood pressure can remain relatively preserved during early compensated blood loss. And choice F is also incorrect because gradual fundal descent is an expected postpartum finding and does not indicate acute hypovolemia. And for our last question, question 10. A laboring client has painless, bright red vaginal bleeding. Which complications should the nurse expect? It's B, placenta previa. Placenta previa classically presents with bright red bleeding, no pain, and soft uterus, while placental abruption causes painful bleeding. Thank you so much for watching. I hope this NCLEX maternity review helped you feel more confident and prepared for your exam. If you found this video helpful, please give it a thumbs up, subscribe to the channel, and hit the notification bell so you don't miss future NCLEX reviews, practice questions, and nursing tips. Feel free to leave a comment below with any topics you'd like me to cover next. Thank you for watching, and I'll see you on the next video. Happy studying!